Hi, welcome to the class. My name's Eric Silk. I'm the instructor for the course, and this is Child Psychopathology. So this is the first screencast lecture in the class, an introduction to child psychopathology. In this course, we're going to use the Abnormal Child and Adolescent Psychology textbook by Wicks, Nelson, and Israel. This is a good textbook. This is probably the last semester that we're going to use this textbook, as there is a new edition out that has some DSM-5 updates. Throughout the class, I'll add the DSM-5 updates on my own, so you'll see the changes between the DSM-4 and the DSM-5, and it'll save you a little money to use a little older edition of the book. So make sure you read your textbooks. That's a primary source of information in the class. There's a lot of reading in the class. Your discussions will be based primarily on the reading, and screencasts will add a little extra to the course and give you the feeling that you actually have a lecture, even though this is an online course. So, to get started in the class, what is abnormal behavior? That's what we're really talking about with psychopathology. So how do you determine what is abnormal behavior in a child, an adolescent, or even an adult? I want you to think about that for a second. What is abnormal? Well, one way that we can look at abnormal is statistically rare. Okay, so this is a bell curve. I hope that you've seen this before. There's some problems with the bell curve, and not all human behavior fits on the bell curve. But for this example, we're using an IQ score here. So the average IQ score for a person is 100. And if you go out one standard deviation from the norm, that's this area right here, 68% of the population falls within one standard deviation of the norm. If you go out two standard deviations, so this total area right here, both areas shaded in light and dark blue, that is 96% of the population. So a vast majority of the population falls within two standard deviations of the norm. If you go out past that, you get 2% here and 2% here, and a little more a little further out. But this is statistically rare over here and over here. So an IQ score here of 70 or below, that's low, and that would be indicative of somebody that has cognitive impairment. If they have impairment in other areas of functioning, you'll learn about that later in the class. And 130, would be a high IQ score. So 130 and above would be somebody that we commonly refer to as being gifted. So is being gifted abnormal? Well, yeah, it is. Is having cognitive impairment abnormal? Yes, it is. Which one would you rather have? Well, probably you'd want to be up here. This might not cause you as many problems as being down over here at 70 or below. So now, I mean, that's not to say the kids up here aren't. I've assessed many kids with a 130 IQ, and they're a mess. They're miserable. They have anxiety and depression. Well, those are abnormal too, and you can think of psychological functioning as being statistically rare or not. Do most people have schizophrenia? No. But the key here is that it causes some sort of impairment as well. It's got to cause impairment. And with an adult, I typically tell my students to think, well, does it cause an impact on the ability to work, love, or play? Work is, your job, your employment, but for a kid, that would be school. Love is your relationship with family, friends, significant others, and then play is the ability to get enjoyment out of life. So does it Is it rare? Does it cause impairment in that area? And that impairment part is really, really important. So does it cause some sort of negative impact? I want you to keep that in mind. Okay, so let me give you a scenario that I run into all the time in my clinical work. I do a lot of assessments with kids, like disability assessments, and frequently I have parents that bring in a kid and they tell me something like, hey, the kid doesn't talk. Well, is that abnormal? I want you to think about that one for a second. Probably saying, well, no, a kid should talk. A kid should talk a lot, often. Is it that the kid is shy? Do they have selective mutism? Maybe are they on the autism spectrum? What would that be? I mean, where is your mind going right now when you think about a kid not talking? Well, pump the brakes a little bit and slow down, because we got to put this into context of a child's development. So the developmental stages. Now, most of you in this class, this is old. You've learned this years and years and years ago. But you have no clue how frequently I ask parents, well, did your child meet all of their developmental milestones? And the parents have no clue what I'm talking about. So the stages of development are really important. And I mean, look at this chart. There's a lot of things here. It's really difficult to remember everything, but you can just kind of look at a chart. So should a 6-month-old talk? No. A 4-year-old? Yes. Where does a child start talking, though? And that's really important. So at 12 months, a kid will typically say a few words like mama and dada or something like that. And then, like, when you talk to the child, do they respond? Like if you point at something and say, look, do they look at it? So it's things like that. You should be really familiar with the developmental stages, developmental milestones, to make sure that the abnormal behavior isn't something normal. Because kids do a lot of goofy things through the stages of development that are technically normal, but an adult wouldn't do. So keep that in mind. This is from the CDC. It's also important to remember cultural norms as well. So just because you're in the dominant culture doesn't mean that you get to dictate what a child's behavior does and does not consist of. Now, in a state like Wyoming, not exactly the most diverse state, but if you leave Wyoming, you'll see lots and lots of different cultures. And different cultures have different norms for child behavior. One example that I always like to use is I used to teach in the Bahamas. And I don't see the Bahamian flag up there, but so I would commute back and forth from Florida to the Bahamas. And all sorts of families would be traveling to the Bahamas, and you'd get a lot of little Caucasian kids that were, well, frankly, they were acting awful. But to me, it just seemed kind of normal. So they'd be yelling at their parents, or, oh, I remember this one little, like, very cute little blonde girl playing with their mother's cell phone, and she got mad and started hitting her mother. And a Bahamian that I was with just lost it. They couldn't believe that a child could act that way. And that's not normal in their culture, but normal in our culture. So you have to be very, very aware of somebody's cultural background. And oftentimes you're not going to know just by looking at them. You got to ask. And keep that in mind when you're trying to determine if a behavior is abnormal or normal. And then there's gender differences as well. So you're going to see a prevalence of a lot of disorders is higher in boys than it is in girls. And it flip-flops with some things. I mean, we'll go through this throughout the chapter, but I want to just give you a quick explanation of why that might be, specifically with ADHD. So I want you to think about what a little boy versus a little girl with ADHD might present like. A lot of times with ADHD, girls are more like daydreamers, whereas the boys will be daredevils. That's the best way that I can describe that. And that term, those terms of description come from a researcher named Barclay. And he kind of talks about how, well, if you were a teacher, which child would you rather have in class, the daydreamer or the daredevil? And so I think the answer is pretty clearly that the daydreamer isn't going to cause quite as many problems. But if a kid is launching off his desk or doing backflips in the classroom, running around, disrupting everyone else's learning, they're going to get referred for psychological services a lot quicker. Because those children that get referred most often, which for ADHD is boys, that kind of defines how we conceptualize the disorder. So the research that's conducted on the disorder focuses on boys, and the boys' presentation of the disorder it's reflected in the literature, but then also in the diagnostic criteria. So it might be artificial inflation of prevalence of these disorders in boys. It might not be. I mean, there's a lot of different disorders that men get more frequently than females. So if you look at the male versus female chromosomes, XY versus XX, that Y chromosome, we're missing stuff. So females in the class usually get excited to hear that, but you've got a backup X chromosome. We as males do not. So a lot of disorders are more prevalent in men than in women. Okay, I also want you to think about situational norms. So what do you do in a given situation? So running around like a lunatic might be okay on the playground. If you're wild and aggressive and pushing other kids, that might be okay on the football field or something like that. But what about when you go to grandma's house? Probably not appropriate. What about the language that you use when you're with your friends? Is it okay to use that language with a teacher or a principal or your parents? Well, it depends on what situation you're in. So keep that in mind, situational norms as well. In the course, we'll talk about prevalence rates, so how frequently a disorder occurs. So here you'll see the prevalence rates for children on the autism spectrum, or in 2011 we just called it autism. So you see a huge increase just in a couple of years. Well, why is that? We're going to get into that material later in the course, but I want you to start thinking about what percentage of kids have problems. Is it a majority? Is it a minority? I mean, we talked about things being statistically rare, but there's a lot of things that can go wrong with kids. There's speech disorders, attention disorders, learning disorders, motor and tic disorders, all sorts of different things. So what do you think the total number of kids with some sort of psychological problem is? What would your guess be? Well, according to the APA in 2007, about 10% of youth have serious problems, and an additional 10% have mild or moderate problems. So about 20% of kids. That's a lot. We're talking one out of 5 kids. So now, just out of curiosity, what percentage of those kids do you think actually get the help that they need and deserve? Well, the fraction's really low, and a lot of different psychological disorders start at different times. You can see the onset of depression earlier in childhood, but bipolar disorder or schizophrenia the onset will be later into adolescence or young adulthood. Autism spectrum disorders you're going to see in early childhood. Some of these disorders, you can have a good, solid impact on the future functioning of that individual with early intervention or treatment. Sometimes that's not going to do much, but you could really help somebody to prevent continuing or future problems into adulthood. So a lot of people ask what causes psychological disorders, and there's lots of different theories. If you go to the history of psychopathology, a lot of people thought that psychological disorders were the results of possession, spirits, demons. We call that demonology. There's other terms for it as well, but that's largely been given up in countries that have good, solid belief in science. But you still see this every once in a while. Even in the state of Wyoming, I have a lot of parents that have children that have some psychological disorder, and they think that it's a curse or something like that has religious or spiritual explanations. And when I talk to them about genetics or genes or the environment, they oftentimes don't like that explanation. They prefer a religious or spiritual explanation. A long time ago, and this ideology is still prevalent today, the idea of somatogenesis. So soma means from body, it really means body. So genesis means creation, so created by the body. And a lot of people think that psychological disorders are the result of some sort of imbalance. How many times have you heard that term, chemical imbalance? Well, we really don't know if there's a chemical imbalance. We don't have a way to measure neurotransmitter levels in humans' brains right now. You might think we do because that's the way it's presented in the media, but we seriously do not have that ability yet. We can measure like metabolites of neurotransmitters in the urine, but neurotransmitters are not just in the brain and spinal cord. Outside of the body, they're the same as many hormones, and it's really difficult to tell if something is out of balance. So this down here is Hippocrates. You guys remember Hippocrates? He was kind of the founder of this idea of somatogenesis, and we would consider him in the West the father of modern medicine. So this idea kind of sticks around, but I don't think that's the best way to conceptualize things. If we were to talk about Freud, he would have all sorts of interesting explanations, oftentimes very colorful and controversial, for what causes child psychopathology. He would probably talk about the imbalance between the id and the superego. Remember different stages of development, the psychosexual stages, the oral, anal, phallic, latency, and genital stages. So you would talk about fixation and regression and different defense mechanisms that we use when id impulses come bubbling up to the conscience. And psychodynamic theory is interesting, but it's probably not best to rely on just that. If we were to ask the behaviorists like Skinner and Watson, they would have a totally different explanation for what causes child psychopathology from Freud. Not that one is right or wrong. I mean, each of these different conceptualizations can be kind of thought of as like an arrow that you put in your quiver of ways to conceptualize different disorders, and they might be applicable to different individuals, but relying on just one is probably not a good idea. I will note that a lot of the interventions for psychological disorders for children that are supported with research are behavioral in orientation. So when we look at these problems, they are very complex. They are biopsychosocial problems, and I like the biopsychosocial model. So bio is biology, like genetics and stuff like that. But we're also talking about hormones and different structures in the brain. All sorts of things can come into play. Psycho is psychological. So your psychological functioning, cognition, that would be behaviorism as well, things that have happened to you, and social as well. So your environment. Remember, like the old nature versus nurture debate? Well, we're almost at the point where we can say that that one's basically over. It's always a little bit of both. So you're always having nature and nurture working together, and that's what we refer to as epigenetics. So these problems are very, very complex, and it's problematic if you try and reduce down these problems to a single cause. So who works with kids? Who are you going to see working in this field of child psychopathology? Well, there's a lot of different letters there. So you might have psychologists who would be PhDs or PsyDs. Sometimes you see somebody that's an ED or educational doctorate. They usually work more in like the schools. Somebody that's an MD, or they could be a DO. So those are medical doctors, or doctors. DO is Doctor of Osteopathic Medicine. Those would be psychiatrists. Sometimes you get neurologists working with children as well. The psychiatrists would typically be prescribing medication. Psychologists are doing more therapy and assessment. So I have a PhD, obviously that's why I put that one first. No, I mean, that's a joke. We're not on top of the list or anything like that. I mean, probably if you put these in order of importance when you're dealing with children, I don't know who to put on top. In a medical setting, obviously it's going to be the MD. But there's all sorts of other folks that work with children. There's people that have master's degrees, and they might have a master's degree in marital or family therapy, or they might just be therapists or counselors. You have people that are social workers, licensed clinical social workers that work with kids. Sometimes there's clinical social workers, nurses. In Wyoming, I actually see a lot of nurse practitioners that work with kids that are prescribing medication, just like the psychiatrist would be. And then, I mean, there's all sorts of other people that would be working with children as well, like speech therapists, speech pathologists, occupational therapists, physical therapists. But if you look over here at this nice picture, I want you to understand that oftentimes it is the teachers that are the front line with the kids that start to understand that the child has a problem. And, teachers are in a really unique position. They work with so many children, and they see so many different behaviors that they're pretty good. A lot of times people will complain that they think that teachers over-pathologize kids. They say that, every boy in the class has ADHD. Well, I mean, they could. It's probably unlikely, but usually teachers are pretty good. And then also, when you're working with kids, you're almost always working within the context of a family. So that's very, very, very important to keep that in mind. I always say, these problems in childhood, sometimes they're genetic, but it's very rare that they just develop in a bubble alone. They always happen within the context of a family, even if it's just the fallout of the psychological disorder on the rest of the family. But the family then works with the child. So Frequently, you will enlist the help of the family to almost work as like co-therapists. You can do parent training with a mother and a father. That works really good in something like ADHD, but you might do psychoeducational sessions or all sorts of different things within a family. So that's most often the case. Not always, but usually. My experience working with kids, a lot of parents would bring in a child for therapy and basically drop the kid off and say, well, it has nothing to do with us. We're just fine. It's the kid that's got the problem. And that was always really pretty hard for me as a therapist to see that kind of thinking in the parent. But it's best if you can, again, conceptualize the problem within the family and then also enlist the family in treatment. So that's it for the introduction to the class. You've got a lot of activities, again, a lot of reading to do, and then discussions. So make sure you do the discussions in the class. That's where a good chunk of your grade is going to come from, and it'll keep you on track so you don't fall behind for the midterm or the final exam. So again, welcome to class. This class always works really well with the discussions. You'll find that the discussions are primarily with your fellow students. I try and sit back a little bit. I read and monitor the discussions, but when I'm not there posting every 5 minutes, I actually get a lot more student participation. So I know some students have a hard time with that. It works pretty good. Once in a while I'll miss something. So if you find something that's offensive or you think you need to bring it to my attention, please email me right away, and it's just esilk@uyo.edu. Respect other people's opinions in the discussions. So you'll learn a lot from that. I hope you enjoy the class. If you ever have any questions, feel free to email me. That's the best way to get a hold of me. Again, it's esilk@uyo.edu. And that will wrap up our first screencast. So have a great semester. Put in a lot of work.